Thanks very much for your invitation to come and speak to you here. And it's fantastic to be in Iraq for the first time. I've seen wonderful things in this country, and we'll stay a few more days afterwards to see some more. I just wanted to introduce you to stem cell transplantation, which is not a familiar topic, but I want to give you an overview of what's involved and where we are up to, and whether this is likely to be a treatment in the future. So why cell therapy? Well, in humans, nerves do not regenerate. This is not a biological thing, because in many animals, they do. Different animals can grow whole legs, tails, involving neural tissue. But in humans, no neural tissue regenerates. And given that the retina is a neural tissue, once it's damaged, it is lost permanently, and you have permanent blindness. There's an obvious treatment, which is replace the missing cells, and that's the route we would like to take. Where might you get cells to replace nerve cells that are damaged? Well, you could get them from the same eye, and we've seen some attempts at retinal transplantation autologous. You can get them from other people, such as donor transplantations, and you'll see fetal progenitor cell transplantation, which functionally comes from another person, or you can use stem cells. So what is a stem cell? Why is it so exciting? A cell in the particular organism which can convert to any other cell of that organism. So it's pluripotent. And also, it's immortal. So you can make as many cells of the type you want to make as you can. If such a cell was available, we'd have to find it, we'd have to turn it into the cell we're missing, whether it be photoreceptors or retinal pigment epithelium. We'd have to implant it in the retina in the disease state, and we'd have to know when in the disease to implant it. These are the things that are required to make a cell transplantation with stem cells. So where do we get stem cells from for human retinal transplantation? 3 sources: embryonic stem cells, human-induced pluripotent stem cells, and adult stem cells. And all of these are currently being used in trials in human retinal disease. What's an embryonic, one behind, okay. What is an embryonic stem cell? Well, an embryonic stem cell is a cell from the inner cell mass of a 5-day blastocyst. One group of cells from this will make all the transplants required for all the people. You don't need one embryo, you need one for everyone. And the same embryo will also make you all of the hearts, all of the livers, all of the lungs. This is the power of the immortality of a stem cell. What about human-induced pluripotent stem cells? These 2 guys got the Nobel Prize for this. It was realized that every cell in the adult has all the instructions for every other cell in the body. And they realized you could reverse an adult cell back to the primitive cell and then use the stored instruction to make a new cell. So you can make skin into retina. You can make tongue into foot, anything like this. So this is the second source. Any adult cell can be turned into a retinal cell. The third source is adult stem cells. And this theory is that left over in your body are stem cells from your embryonic life. And the sources are mixed populations. And you'll see, and these are familiar, they are things such as bone marrow, cord cells, or adipose tissue. And this is the most common source of stem cells that you hear about people going and having stem cell transplantation. Do we put the stem cell in the body? We would like to put the stem cell into the eye, and then it turns into the eye cell. It doesn't work, the cell dies. So you have to make the cell you want to transplant in the laboratory and then transplant it. You could put undifferentiated, but these do not differentiate into retinal cells in situ. You can use progenitor cells from fetus or other sources, or you can fully differentiate cells, and I'll show you examples of this. You can make human retina in the laboratory from any adult or embryonic stem cell. And the second thing is sometimes you make a single cell type, retinal pigment epithelium or photoreceptor, and sometimes you put in a multiple cell tissue, such as a combination of RPE and photoreceptors. Here's an example from our laboratory where we can take an embryonic stem cell, and by moving it through all the stages of embryonic development, make human multi-layered retina consistently in the laboratory, so all the cells of the human neuroretina can be generated. We can also do that for all the vascular components of retinal and choroidal vasculature. So we can make pericytes, we can make endothelial cells, and we can make smooth muscle cells for vessels. So not only the neuroretina, but we can make retinal pigment epithelium and all the blood vessels of the retinal and choroidal system in the laboratory before you transplant. How do you implant? Well, you have to choose once again. You can put in a suspension of photoreceptors, you can put in a sheet of photoreceptors, you can put in a suspension of RPE, a sheet of RPE, but each of these has to match the disease and the technique that you're going to do. Then you have to create a tool to deliver such a sheet or a suspension, and then you have to decide whether you're going to do it manually or with a robotic system. So here's some examples. This is a delivery technique of a classic subretinal injection with a 41 gauge cannula, which gives you a retinal detachment. That's transvitreal, and this is a technique, I think I've gone the wrong way. This is a technique using suprachoroidal delivery into the subretinal space. So you've got to choose the way you deliver your stem cells, which you've already decided at what stage of differentiation they are. Here, this is the technique we use to deliver a patch of RPE under the neuroretina, 3 millimeters by 6 millimeters by 20 microns. So you also have a scale issue. And here's another patch which was developed by a US group. So here we deliver patches of RPE. So you've got to make a tool that allows you to deliver the patch. And of course, you can either do it manually or you can do it by robotic systems. And you can see this is the current precise robotic system which you can go and buy to do retinal surgery. This is a system we're developing now for human stem cell transplantation. And these are a choice of all the robots that are currently being developed for human retinal surgery. And lastly, you have to decide when in the disease you're going to give your stem cells. So it could be one, wet or dry, RP, Stargardt's disease, vein occlusion. You've got to know what you're going to treat with your new cells, and you've got to know when. Before it comes, early in the disease, late in the disease. So all of these questions have to be answered to generate a new treatment involving the creation of retinal cells in the laboratory with secondary transplantation. So where are things up to now? What sort of trials are being done? So here was the first one. This is the first trial done, 2012, suspension of RPE cells, source, embryonic stem cells, delivery technique, subretinal injection transvitreally. And what they showed is the cells survive, the cells don't become a tumor, the cells don't cause an immune reaction, and there's very limited but suggestion that you may get some bystander efficacy in terms of acuity. So these are early studies looking mainly at safety.
Macular cell, yes.
Here's another one looking at subretinal injections of umbilical. This is adult stem cell, mixed population, given in the suprachoroidal space. Delivery problematic. 6 out of 13 with retinal detachments, and lots of problems with the delivery. But the cells are safe, and there's some suggestion of efficacy. Here's another case, adipose tissue injected directly into the vitreous. Poor preparation of the cells, secondary massive proliferation, and blindness in 6 patients. So very cautious about doing these new techniques, because even when you do it all relatively well, you can find this sort of problem early because you don't fully understand the pathophysiology. Here's another one, human retinal progenitor cells. These are from fetuses prepared, subretinal injection, early improvement in visual acuity, doesn't last more than 6 months. Another one, intravitreal adipose tissue CD34 positive, some increase in visual field in retinitis pigmentosa, some increased in perfusion in retinal disease. IPS, this is retinal pigment epithelium made from the patient's skin and transplanted back in. Once again, safe, feasible, no visual recovery. Human retina, created in the laboratory from the patient's skin, transplanted back into the patient. Safe, no tumors, improved fixation. Very low quality efficacy, but safety. This is our transplantation, patch transplantation, severe wet macular degeneration, improvements in visual acuity and in reading, sustained for 3 to 5 years. So good acuity data, very small number of patients. So this is the challenges. We've got a source of cells well characterized. If you want stem cells, we have them. We can make the cells, but we don't know which form to implant them. We don't know how best to implant them, and we don't know when in the disease. So since 2012, over 100 patients have had transplantations, no major safety signals from the cells, many from the delivery techniques and surgery. There's significant toxicity for some preparations of adipose. There's some early suggestions of efficacy, and currently no FDA approvals. It promised to be very powerful, but we're a long way from being in control of it. Thank you.
Thank you very much, Dr. Cruz, for this interesting topic.